Dear Chairman, dear colleagues, it's a great pleasure for me to be part of your 11th annual meeting. My topic today will be the degenerative cervical myelopathy. By definition, this is a spinal cord dysfunction secondary to extrinsic compression of the spinal cord and/or its vascular supply from degenerative disease. There are different entities: cervical spondylopic myelopathy, OPLL, the ossification of the ligamentum flavum, and the degenerative disc disease. In my presentation, I would like to focus on CSM. You're all familiar with the clinical symptoms and complaints. In many patients, we see numb and clumsy hands and the impairment of gait as the main symptoms. Clinical signs can be corticospinal distribution of motor deficits, the atrophy of hand intrinsic muscles, and other clinical signs. For the diagnostic workup, we need at first a detailed neurological examination to calculate the JOR, and then we also need the information about the event potentials like the SSEP or MEPs. The imaging, we have the plain films to detect segmental instability, functional X-rays, and the main imaging modality, of course, is the MRI. Here we can see the extension and the location of the stenosis. We can see if there are any intramedullary signal intensity. We also think that the CT gives another very important information. So you can see if this is a soft disc or a hard disc, if there are signs of OPLL, and you can also see the location of the stenosis. Surgery is recommended, and there's no doubt, if there's a progressive clinical myelopathy or severe myelopathy. It's more difficult when we have mild to moderate myelopathy. Here, we more choose surgical treatment when we have younger patients or we have intramedullary signal high intensities or circumferential compression. It's difficult to discuss the indication for surgery with asymptomatic patients. Here we ask for spinal cord injury in the medical history, we ask for high-risk activities, and of course we see if there are pathologicals evoke potentials. From the surgical approach, if we have mono or bisegmental stenosis, our favorite approach is from anterior. In monosegmental cases, you can choose an ACDF with or without plating. In bisegmental cases, you can either go for bisegmental ICDF or you can perform a corpectomy with and without plating. And in selected cases, like in this pincer stenosis, it may be helpful if you perform surgery from anterior and posterior with decompression and instrumentation. More difficult is to judge the approach in patients with multisegmental myelopathy. This is a paper by Lawrence, published 2013 in Spine. It's a systematic literature review, and it discussed the effectiveness of the different approaches. So when we look at this data, especially the outcome parameters and the safety profile, the authors conclude that an individualized approach is recommended to account for pathoanatomical variation. To fulfill this, we developed a 7-letter coding system to support the decision-making for the surgical approach. We recently published this coding system, and the main purpose of the publication of the study was to validate our coding system. In conclusion, we could find that there was a very good overall reliability for our system, and that it helps especially less experienced surgeons to analyze the pathology in a structured manner so that the relevant clinical and imaging parameters could influence the choice of the surgical approach. I would like to give you an example. Here you can see our 7-letter code. It's important to know the compression, location and extension, so C2. The alignment and instability of the spine makes it 2 for an S, the morbidity and the C modifier where we look for the key line. This is an example, 69-year-old patient with moderate to severe myelopathy. You see the MRI and the CT scan. The compression is combined from anterior and posterior, so that gives it a PC. And then we have an extension of 3 levels, so there's AP from an F for an anterior or posterior. When we look at the X-rays, we see it's almost straight. So there we have AP for a kyphotic or straight alignment, and we have no signs of instability. So for instability we have an 0. When we look at the morbidity, Asia 3, this gives it P, and because there is no relevant bone disease and the C modifier key line is positive, there we add 2 zeros. So overall we have 4 P's and only 2 A's, so that makes it a posterior approach where you can either go for laminoplasty or for laminectomy and fusion. In multisegmental cases, of course, there might be also the indication for an anterior approach. You can go for a multisegmental ACDF with plating, but you can also go for a combined approach, and this actually is my favorite approach in these cases, where I can decompress 2 levels with a corpectomy and then 1 level with an ACDF, and of course additional anterior plating. In seldom cases with a severe kyphosis or an extension of the pathology to the cervical thoracic region, it might be necessary to combine an anterior corpectomy, in this case of 3 levels, with a long posterior instrumentation. When we only look at the posterior approach, our favorite technique is the open door laminoplasty. We perform this laminoplasty by a unilateral approach. This was first described by Rosselli. It's an effective decompression with less approach-related trauma because you dissect the muscles only on one side. Of course, there are strict indications like you should have no kyphosis, no instability, and C2 or C7 should not be included. Like you can see here in the MRI postoperative, you have a very nice decompression, and on the other hand you can keep mobility. Like in the functional X-ray, you see mobility of the subaxial cervical spine 1 year after surgery. When we combine laminoplasty with the conservative technique or conventional technique of laminectomy and fusion, you can see operation time is shorter in our experience with the laminoplasty. You have less muscle injury, but if you have patients with neck pain, they do better with the laminectomy and posterior fusion. You can also develop secondary kyphosis with the laminoplasty, so their laminectomy is the favorite technique. Decompression is pretty much the same, but you have less C5 palsy with unilateral laminoplasty, and our experience is more than 100 cases for both techniques. And the reason for that could be that you have a less shift of the spinal cord. So when we look at the outcome, there were 2 clinical studies just recently published from Canada and from Norway. They looked at the patients with mild, moderate and severe symptoms, and they all showed improvement outcomes. Significant improvement was also seen for the PROMs. 45% experienced complete recovery, and they found 28% adverse effects within 3 months. This is a figure from the Norwegian study, and you can see here that a lot of patients, more than 70%, were improved by the outcomes due to surgery. So in summary, we can say that there's no conservative treatment option in DCM to improve myelopathy. The diagnostic evaluation should include a detailed neurological examination, MRI and plain and functional films and CT. Indication for surgery depends on the severity of myelopathy and the progress of symptoms. And in asymptomatic patients, other aspects should be taken into account, especially the history of a spinal cord injury. For mono or bisegmental DCM, the anterior or combined approach is favored. For multisegmental DCM, we developed the 7-letter code to decide on the approach, and our favorite technique here is the unilateral laminoplasty. With all these techniques, the outcome is very good, and so it is worth to go for surgery. Thank you very much.